Well, we are very fortunate to have Dr. Zio Gokoslan to present on Zoom this morning, Grand Rounds in a combined orthopedic neurosurgery forum. He is the current chair at Brown, and he is currently the chief of neurosurgery at Rhode Island and Miriam Hospitals and the clinical director of the Norman Prince Neuroscience Institute. He is also the Julia Stoll Professor of Neurosurgery and Director of Complex Spine Surgery Fellowship at the Warren Alpert Medical School of Brown University. He leads also the Spine Institute there as well, and works with an entity called Lifespan, which it's an integrated academic health system that's kind of unique to that area. I don't know if he has any comments about it, but it's very interesting. It was founded in 1994 and has been successful. A little bit about his background. He and I have been friends for a number of years. He earned his medical degree from the University of Istanbul in Turkey. He was the valedictorian of his class. He completed an internship in general surgery, a fellowship in neurotraumatology, a residency in neurosurgery at Baylor College of Medicine in Houston, and then his fellowship was at NYU. He then spent about a decade, correct, Zia, at MD Anderson, almost. And then from there, he went to Johns Hopkins, where he's vice chairman in the Department of Neurosurgery, and director of the Surgical Spine Program, and director of the Spine Metastases Center, as well as a professor, not only in neurosurgery, but oncology, orthopedic surgery. And when I had the opportunity to visit you there with Frank Frasica, I mean, it was evident that you also functioned across departments very well. He is a recipient of numerous prestigious awards and an active member of several professional societies. Many of those are faculty awards that are very prominent. He has over 500 peer-reviewed publications and 60 book chapters. He has trained more than 100 residents and fellows, and as H-index is 90, which is extremely high, and at over 50, those are the people that are National Academy of Medicine and have achieved those things, those statutes. He has over 33,000 citations. His practice focuses on complex spinal reconstruction, and we share that interest together. And he also works on primary and metastatic disease. Has a focus too in many years over the sacral neoplasm and spinal cord tumors. We're very fortunate to have Zia here today. I consider him a dear friend, and I really appreciate this. Alan, would you like to please make some comments? And thank you for, we appreciate all the neurosurgery faculty here, residents and students, and it's great to be here together this morning. Thanks. Alan?
Yeah, just a couple of words, otherwise there won't be any time for Zia's lecture. And you've caught about everything. I mean, the only other things is former president of our joint spine section, and just, widely regarded as a technical wizard in spine oncology and neurosurgery. And, when I was growing up, I always looked to the literature to get what's going on in spinal oncology from Zia. So thanks for sharing your knowledge with us today.
Well, Fran and Alan, thank you so much. And I'm really honored and feel very privileged to be at the Grand Rounds today in this joint function. And it's great to see this. I was trained in a joint neurosurgery, orthopedic surgery fellowship training program, and it was a great experience. And so always appreciated the wisdom and the teachings I've received from my orthopedic colleagues. So, both Fred and Alan, we go way back in terms of our relationship professionally over the years. I'm going to share my screen here to see if we can bring my slides up without any technical issues here. Are you able to see them?
Yes, but it's not in the presentation mode, but we can see the slides.
Well, let's see if we can get there.
All you have to do is hit the.
You can go ahead and hit slideshow.
Let me do this. I'm gonna just minimize it and get it to the presentation mode before I turn it on.
Cursor appears to be right on the presentation.
Uh, Could I?
Yeah, while you're working on that, everybody mute your microphone, please.
But I could sign off and come back in because I think it's gonna be tough to fix this now.
Yeah, no problem. Go ahead, go ahead. Yeah, this morning I had some technical difficulties too, because there were two links actually.
I did too. Do you know that we have 96 participants this morning?
That's great. We have that many people in neurosurgery and orthopedics. That's pretty good.
And I noticed we have a participant from Sweden.
Yeah, Bjorn,
I don't think Bjorn's on this morning.
Nate, how are you this morning?
Very well. Nice to see the teams working together.
No, thank you. And I met with Jake yesterday, again in the afternoon. Mark and I did.
Great.
So we hope to get something to you with regards to that. So
Perfect.
I was thinking back to Frank Eismont and Barth Green, and I started the combined orthopedic neurosurgical spine program many years ago. And I think it's the prototype for the whole country.
well, and they think the University of Miami, they certainly think of spine. So it may be when he's going to the share of the screen that he's it's not yeah, if he has dual screen, maybe he's not pulling up the right screen. I don't know.
Right. Not choosing the full screen.
Correct.
Marcella, is there any tip you can give?
I was just about to reach out to him because I wasn't seeing him on the.
Can you call him or something? Maybe?
Yes, that's what I was about to reach out to him. 'Cause I don't see him on the session. Give me one second.
We've all had these technical problems before. In the old days, I mean, Mark, you remember when we used to have the slides?
And I remember one academy meeting.
2x2s or whatever they were, and you'd have the slide decks and you'd have the carousels, and you'd be putting those together on the plane going to the talk.
I remember Bill Fielding giving his presidential address to the American Academy of Orthopedic Surgeons, and somebody went to change the carousel. Of course, he had 3 carousels going at one time, and
They dumped all the slides.
he dumped all the slides.
I think Frank used to work on his talks on the plane with his slides,
Always.
right? See,
For sure.
When we started out, at least when I started out, we used to use glass slides.
Glass
Mark, I
slides?
remember the
Yeah, they were-
backgrounds I had to give, and I had no.
That's Benjamin Franklin time.
Yeah.
No offense, Bert.
True.
I bet some of the residents have never seen those little 2x2 slides in a slide carousel. And when you loaded them, you had to load them in a special way. You had to turn them, you had to twist them, turn them upside down, and then, anyway, it was things have changed a lot.
When I was in medical school, we still had grand rounds in the pit at Jefferson. And they were usually involved a case presentation of a live patient.
Yeah, it's interesting. When I was I went to Hopkins twice. Oh, here it goes.
There we go.
It looks like we're making.
There you go. Oh,
There it goes. Good.
we're good, Zia.
We're good. We're good.
Okay, everybody mute.
Everyone but Zia.
Everybody would see it.
Who we're not hearing.
We can't hear you, Zia. You're talking. We can't hear you. Marcella, you better call him and let him know we can't hear him.
I'm trying to find him so I can unmute.
Oh, there you go.
How about now? Can you hear me?
Yes, we can hear you now. Yes.
All right, so I'm so sorry about these technical difficulties, but let's go and get started with the presentation here. Over the last 27 years or so, we have done really quite a few surgical procedures here. As you can see, about 5,300 cases. Of all those, about 10% of them were primary tumors. And of those, if you look at our breakdown in terms of the en-bloc resections that we performed, and this is an old slide, but nevertheless, it gives you a sort of a sense of what the breakdown of the cases are like. A majority of them were chordomas, some chondrosarcomas, and other types of sarcomas, and a number of other benign tumors, and a few metastases, mainly renal cell carcinomas. But we've learned a great deal from this experience over the years. This is the work that we have done with AO Spine Tumor Knowledge Forum, and as you can see from very large multi-institutional, multi-center databases, we extracted almost 1,500 cases. And of those cases, the chordomas were the most common, as you would predict. We looked at chordomas specifically, and this has been widely published now. And our purpose here to determine whether or not we can really clearly demonstrate any appropriate surgical procedure would offer survival benefit as well as benefit in terms of the local recurrence. And as you can see, the data clearly indicates that when we are able to resect these tumors with negative margins, we can really achieve very good results for our patients overall. Having said that, we don't necessarily eliminate the risk of recurrence, even in patients who undergo en-bloc resection with negative margins. This is our experience looking at sacral chordomas from Johns Hopkins many years ago. And in this particular series of cases, we attempted to resect the tumor in an en-bloc fashion in every case that came to our institution. As you can see, we were able to achieve that in some of the cases. In others, we were not able to do so. And anytime we failed to do that, the patients really did very poorly. As you know, all chordomas are not the same, although a lot of people don't necessarily pay attention to that. The most common variants that we see are the conventional long chondroid but we also see the differentiated chordomas and the newly described entity, poorly differentiated chordomas, particularly in pediatric patient population and more commonly in the cervical spine. And this is the one that is associated with INI1 deletion. The differentiated chordomas typically do not stain for brachyury, which is the primary staining technique for chordomas. If you look at the clinical characteristics of these various histologies, as shown here from the group from MGH, there is significant difference in survival, particularly as it relates to poorly differentiated chordomas. They tend to have the worst possible sort of survival compared to other variants. Not every chordoma really requires an en bloc resection. Here's the patient who has had multiple recurrent chordoma in the upper cervical spine, presented with cervical myelopathy. And this patient, like other skull-based tumors, were really treated in using an endoscopic transcervical approach. And you can see some of the early work that we did here from Johns Hopkins using this type of tubular retractor with image-guided navigation. In the operating room, the tubular retractor was fashioned for this particular procedure. This is actually used for odontoid screw replacement, but we modified that at that time using a combination of drills and endoscope as well as image-guided navigation. These tumors can be very nicely resected through a minimum invasive approach through the neck. And here's a setup in the OR showing the image-guided navigation, endoscopic setup. And this is almost 15 years ago now that we've done this. And you can see you can achieve great resection and decompress the spinal cord. This patient also had proton beam and other types of radiation. Eventually, unfortunately, died several years after this surgical procedure with progression of the disease. Another example here, anytime it is feasible to remove the tumor with en bloc in an en bloc fashion with negative margins, we would attempt to do that. And you can see a patient in the upper cervical spine with an upper cervical spine chordoma. That's a highly extensive disease with both precervical and intracanalicular extension here with involvement of the vertebral artery on the right side. And this patient, it's an old slide just to illustrate at the time the types of instrumentation that was available to us. We have been using wires and other things at the time, but we believe that resecting the tumors in en bloc fashion with negative margins really can make a big difference. And here is the area of interest after the cervical decompression, showing the vertebral artery on the left side that has been completely skeletonized, as well as on the right side, the proximal and distal vertebral artery. The nerve roots have been transected on the right side, and eventually we typically place a silastic sheet ventral to the thecal sac to be able to separate it from the tumor to identify the planes during the second surgical procedure for extraction of the tumor. And subsequently, the patient underwent a very extensive instrumentation as shown here. The second stage is performed using a transmandibular circumglossal approach. And this is borrowed from our skull-based surgeons. This gives you a very nice exposure of the clivus and the upper cervical spine, and you can identify all the important clinical structures here: lingual nerve, hypoglossal nerve, etc. And here's a view in the operating room where you will see the tumor behind the carotid tucked in, and you can see the edge of the mandible where the hook is attached to. And as soon as as long as the mandible is in place, it's very difficult to top of the tumor to be able to disconnect it from its attachments. But if you were to split the mandible as shown here, that gives you great access to the clivus and upper cervical spine. As you might remember, this tumor has been completely disconnected from the back, so you can be accessed from the front and then removed through the mouth. And that's how it looks like after the resection of the tumor. You can see the vertebral artery on the left side, the transected nerve roots on the right side here, and the depth of the incision. And this is the close-up view of the right side of the carotid vessel. And this area then reconstructed originally with fibular strut graft here, as you can see. We tried to couple this with a cage, despite that extensile instrumentation. Posteriorly, the patient, before even leaving the hospital, had failure of this construct. And then we had to bring him back and do a second surgical procedure here as shown. Use a cage to be able to augment the anterior column that was used both as a cage as well as a plate. We cut it a little longer in the front, and so that we could use it as a plate to lower the profile in the back of the throat there. And then here's our artist illustration showing how this construct really put all together and the structure that had been sacrificed on the right side. And here's the patient specimen that has been removed in one piece as shown here. And here's how the specimen correlates to the MRI images. You can see even the third vertebrae here at the caudal end, where there's a little bit of hyperintense signal on MRI, definitely contains tumor. Now, going back to reconstruction of this area, we learned really the hard way that reconstructing the anterior column, particularly when you resect the C1 and C2, is not really the way to go because of the way that the weight is transferred from the base of the skull to the anterior cervical spinal column. And for that, you can see how this is transmitted, and hence instead of reconstructing the anterior column, you really need to transmit the weight from the occipital condyle down to the lateral masseter and then the anterior column. Just to illustrate that point, this is a patient with a cervical epithelial sarcoma that I treated. And this patient initially presented to physicians in Israel and Tel Aviv and underwent an urgent cervical laminectomy because of quadriparesis. A small biopsy was performed. You might see it in the back of the tumor here. And this proved to be epithelial sarcoma. The patient was referred for additional radiation and chemo, and medical oncologist said that, you have to remove more of the tumor for us to be able to do anything. And this patient eventually ended up coming to us for surgical treatment urgently. And here's the patient's MRI on axial images. It's a very extensile tumor involving the right side of the neck, the right vertebral arteries encircled by the tumor. Not only the tumor is in the spine, but also extends into the intradural compartment, circumferentially enveloping the spinal cord. And so we had to really design a very complex procedure to resect this tumor. I really did not have a lot of faith in this operation. I was trying to achieve palliation, but when we started going and moving forward during the surgical procedure, we were able to really resect this tumor eventually completely. Originally, we were going to do a two-stage surgical procedure, but we were able to resect all that from posteriorly. And here are the artist illustrations showing how this really was accomplished. We came from the back and did a multi-level laminectomy procedure. As you can see, the dura was open. We removed the intradural component of the tumor that disconnected from the spinal cord, cut the C1, C2, and C3 nerves on the right side, and then resected the dura with that. We were able to unfold the tumor, so to speak. The spinal cord was not infiltrated directly by the tumor. And then we went ahead and you can see the more detailed illustration here. But the key to this operation was to be able to cut the contralateral pedicles using a bone scalpel as shown here. And this allowed us to disconnect the tumor from all of its attachments as well as from the spinal cord, and eventually extract this after the sacrifice of the right-sided vertebral artery, all from posteriorly as shown here. And then the dura was reconstructed. Here's the dissection all from posteriorly from the posterior pharynx and some of the vessels in the front, but we were able to do that all from posteriorly, given that this corridor was now quite large after the sacrifice of the upper cervical roots as well as the vertebral artery. And here is a tumor specimen showing where the spinal cord used to be, and you can see that tumor that was intradural, and you can see the edge of the dura that was resected along with the specimen here. And here is the patient's CAT scan showing how that looked like after the surgical procedure, with the cervical spine really missing in the upper cervical region. And this was reconstructed, as I was trying to make the point earlier, using a cervical lateral mass cage. And this was placed from occipital condyle down, and it was connected to the rods posteriorly using false cervical lateral mass screws, so to speak. And then this was connected to the posterior construct that was attached to the cervical, the pedicle screws in the thoracic region. And that's how the weight was really transferred from the skull all the way down. And that's how it looked like in the OR. The patient's head is on the right side and the feet are on the left side. And here is the area of interest. You can see multiple dural patches that were used in order to reconstruct the spinal dura here. And then the cage on the right side is visible with the lateral mass screws here. Here's the patient's postoperative MRI. I did get a call from our chief resident indicating that there's a large pseudomeningocele here. We have to do something about it. But the patient was asymptomatic since we did not really go to the patient's mouth. this really did not pose a problem, and then eventually the patient ended up healing. This patient subsequently received, here are the patient's postoperative CT scans, right, immediately after the surgery, and showing the cervical lateral mass construct and how was this position from the occipital condyle down to the cervical lateral masses. More recently, we have been, this patient subsequently received both stereotactic surgery as well as systemic multimodality chemotherapy. Believe it or not, the patient is almost 10 years out from the surgical procedures and disease-free at the moment. Since then, got married and had 2 children and has done exceptionally well. I really did not have a lot of faith in the long-term durability of this procedure, but eventually this proved to be the case here. And again, this goes to show you what sometimes you can do with some of these sarcomas. Here is what we have been really doing recently. We have been printing the patient's tumors, patient-specific 3D printed models are being prepared, as you can see here, and we use them in the operating room. That really actually is incredibly helpful, particularly for our trainees to be able to visualize this tumor these tumors in a 3-dimensional fashion. And it serves as a guide. You can see in the corner here, we are working with our thoracic surgeons and showing, how the tumor relates to subclavian artery, for example. Here are other examples of thoracolumbar chordomas and cervical thoracic chordomas and some of the Ewing sarcomas involving the sacrum that are printed using 3D printed models here. We also take full advantage of the image-guided technology in the operating room that we extensively use, of course, for brain cases. This is our experience looking at sacral chordomas and how we are able to map the tumor in the operating room. In this instance, we have intraoperative CT scanner, and so that we can actually get an intraop CT and map the tumor on the patient's pre-op MRI scan, and that's superimposed on the CT, and then we use the CT scan for image-guided navigation as shown here. And here's an example where we have a large cervicothoracic chordoma involving multiple levels. This was an ER physician who presented with right arm weakness as well as Horner syndrome. Initially thought to have a Spears-Salkus tumor, but this patient turned out to have a cervicothoracic chordoma. This was, here's the patient's 3D printed model showing the tumor as well as the other anatomical structures, how they relate to the tumor, which we use in the OR as a tool to guide us. This is how we are working with our thoracic surgeons and other surgeons in the OR using these 3D models. And in this particular instance, we designed a 2-stage surgical procedure. First from the front using a sort of a modified trapdoor exposure to disconnect the tumor from the rest of the vertebral bodies and then come back from the posteriorly and extract it. And here is the patient's thoracotomy as well as a trapdoor exposure. And this is what we are able to do in the operating room. You can get an intraoperative CT scan when the patient's chest is open, as you can see here. The tumor is superimposed in the back, and you can really visualize that this is how it looks like on the superimposed CT scout image in the OR. And then we can use that, couple that with the image-guided navigation and make these osteotomies across the vertebra in the front. And that disconnects the tumor from the healthy side on the left side. And then we can come from posteriorly and extract this like we would do with a Spears-Salkus tumor, and the cervicothoracic region is reconstructed in the usual fashion with cervical lateral mass screws and thoracic screws. Here's the patient specimen that was removed in one piece with negative margins. And here's how it looks like in the operating room when you do the CT scan with the missing ribs as well as the reconstruction. You can get the ghost image of the reconstruction, how that sort of alignment is and so forth. You can assess all of that in the operating room. Here's another case where we take full advantage of the image-guided navigation as well as intraoperative tumor mapping. You can see that we mapped the tumor on the patient's pre-op MRI scan. That's a thoracolumbar chordoma case. Here's a 3D printed model of the tumor on the left side, and there you can see how it correlates to the MRI and CAT scan. Here's in the operating room where the tumor is completely painted orange. based on the pre-op MRI, which is then superimposed on the CT scan, and then we are using the image-guided navigation to stay outside the tumor when we are doing osteotomies around the tumor. And here is the second stage of the surgical procedure after the first stage where the tumor is disconnected from the back and then will be extracted through the chest here, and that's how it looks like. And you can see the spinal cord. We had to cut multiple thoracic nerve roots here, and then what it looks like from the chest, and then eventually extracted. And here's the hole where the tumor used to be at the thoracolumbar junction. Spinal cord can be seen in the middle there. And this is the patient's postoperative reconstructed image, and postoperative actually 3D printed model showing how this was all put together eventually. This is a lumbosacral chordoma case involving 3 levels. This was again approached in 2 stages, one from posteriorly with a extensile thoracolumbar sacral and pelvic exposure, multi-level laminectomies. All these nerve roots are really dissected out extensively into the retroperitoneal space. And then the spinal cord is freed up from the tumor. Then we place a number of wires here. Let me point them out to you. We have 2 2-meter wires here. One is placed above the tumor, another one below the tumor across the disc level and the vertebra. And then another 2 wires behind the construct, which will be used to secure the cage anteriorly during the second stage of the procedure. And then here's the first stage of the operation. The patient's legs are on the right side. The head is on the left side. Multi-level laminectomy. You can see the nerve roots here extensively dissected. 2 sets of wires ventral to the cord or the catechoina. Here is the tomato saw, and the posterior wires are going to be used to secure the cage. And here's the second stage of the operation, during which the tomato wires are extracted. Midline laparotomy, the great vessels are split, and then we can extract the wires and use them to really section the spinal column precisely, and then resect the tumor and reconstruct the area with a cage. And here is the patient's specimen that has been removed in one piece with negative margins. Here's the intraoperative view through the abdomen, through a midline approach. The patient's aortic bifurcation is here. You can see that, and the common iliac vein is pulled over, and you can see some of the wires anteriorly. At the bottom of the construct on the right side, we are looking at the end plate of S1 there. And here's the patient's plain X-ray study showing how this construct was all put together, both anteriorly and posteriorly. It's very important to have an exact fit in the space here, and you can see some of the wires that now we use to secure the cage to prevent the cage kick out, and then we place a screw into the vertebral body above to be able to secure the cage further there. And here is a specimen how that really correlates to the lumbosacral tumor that's seen on the images here. Now, there's no question that we cannot really talk about chordoma treatment without talking about radiation, and there are various options here: stereotactic radiosurgery, proton beam, and then the proton beam can be pencil beam or others. And these technologies allow you to give a lot of radiation to the remaining potential tumor bed. Carbon ion therapy, although it's not available in the United States, being now used in other parts of the world to treat chordomas, and it's obviously a much heavier particle than the proton beam, delivering a lot more energy to the target. This shows you biological equivalent doses that are delivered to the tumor using various technologies. You can see the proton beam, close 70, 75 grays, quite typical with that. Carbon ion actually delivers almost 105 grays of radiation to the target. And then if you look at the stereotactic radiosurgery with a single fraction, 24 gray, you almost a biological equivalent dose of that is about 150 gray. So very high dose of radiation it can be given to the remaining target, both in the mobile spine as well as in the sacrum. And this shows you some of the earlier results using these various technologies. Of course, we know quite a bit about the proton radiation, achieving fairly reasonable results, both for local control as well as overall survival. Many of these patients also had surgery, so it's hard to extract exact impact of the radiation treatment, but it's certainly promising, particularly with carbon ion when it's used upfront for sacral tumors. However, the grade 3 toxicity is pretty common with these high doses of radiation, as well as some other issues with protons, for example, secondary malignancies is still a concern. And almost all of them, when you radiate the sacrum, you have a risk of insufficiency fractures there. And here's an example of insufficiency fracture, which is it can be treated with sclerotic remodeling and observation, but sometimes they require surgical intervention. These are some of the techniques that are used to get the rectum away from sigmoid vessels, the bowels away from the target of the radiation, since they are quite susceptible, by using tissue expanders. And then this is some of the work that we've done in the laboratory to understand the biology of the chordomas. This is everybody's familiar with brachyury that's used not only as a potential target for treatment, but also to make the diagnosis of chordomas. This is a T gene encoded transcription factor. It is you see the amplification of this or duplication of the gene in some of the familiar chordoma cases. We've done some early work in our laboratories when I was at Johns Hopkins trying to actually grow chordomas in animal models, which was very difficult, but eventually we were able to do that successfully, which is called the Johns Hopkins cell line number 7. After 7 attempts, one of our residents were able to do that in the laboratory. And here's the animal model with subcutaneously injected chordoma from one of my sacral chordoma patients, and growing the chordoma, and you can see the brachyury staining, which is positive here. And then we use therapeutic strategies using small RNA to block the activity of the brachyury, showing that we can stop the growth of the tumor, indicating that the brachyury is the major driver in these tumors. Also, if you look at the signaling pathways in these tumors, these are all tyrosine kinase surface cell receptors that really drive brachyury through various signaling pathways within the cell, and all can be targeted, and they are being targeted currently for treatment of chordomas. Cell cycle inhibitors, CDK6 and 4 were also targeted with a variety of drugs now, and these are some of the clinical trials that are available to chordoma patients targeting various these surface receptors, brachyury, EGFR, PDGFR, CDK, and then the checkpoint inhibitors are being tried now, both as an adjunct with other chemotherapeutic agents, as well as an enhancer for radiation. We also did some genomics work. So, for example, this is our work with AO Spine Tumor Knowledge Forum, looking at single nucleotide polymorphism. And the presence of this appears to be protective, which is quite common. Absence of this, unfortunately, is associated with very poor outcome. And this is really a replacement of one nucleotide with another. And you can see if you do not have the polymorphism, all of our patients die within 6 years, whereas presence of this polymorphism appear to be protective. We also looked at the human telomerase reverse transcriptase promoter region mutations in chordoma patients. And again, the presence of this mutation appeared to be protective, whereas absence was associated with poorer outcome. This is showing the difference between the two. Presence of mutation was associated with 100% of the patient being alive at 10 years, whereas the absence of that was associated with 67% survival at 10 years. It appears to be a significant, again, factor. So in summary, I think it's important to understand the biology of spinal tumors in general, but also chordomas in particular. I hope that I was able to convince the crowd here that block resection of these tumors, can be done safely, and then it can improve both, increase overall survival as well as decrease recurrences. And then the emergent data is certainly suggesting that the focused radiation treatment in chordoma, both as an adjunct as well as a primary treatment, can be can be very helpful. Just take a moment to again thank the crowd here. I think I had exactly 45 minutes given, and despite the delays, we were able to get this to the point. I know that there's a very substantial expertise in the crowd here when it comes to treating chordomas. So I would love to hear Frank's thoughts and others. But these are some of the things that I've learned over the years in treating these challenging tumors. Thank you.
Thank you, Zia. That was a great talk. We appreciate it greatly. Maybe before some others have a question, one of the things that we found, especially in some of the sacral tumors, is when there was lymph node involvement, those patients all succumb to their disease relatively rapidly. And so I think we're learning more about the immunology of these tumors. Just your thoughts. I mean, you touched on that as well.
Yeah, absolutely. And also, a lot of the literature in our own experience suggests as well, the size of the tumor matters. In some series greater than 5 centimeters and others greater than 7 or 10 centimeters. Those tumors, the patient with those types of lesions tend to do much more poorly. And if you look at the imaging studies, when there's extension of the tumor through the piriformis muscle or some of the sacral spinous or sacrotuberous ligaments, they also tend to carry worse prognosis, particularly as it relates to local recurrence.
Yeah, the size of the tumor seems to be a huge factor. I know Patrick Boland always comments on those tumors that are certainly greater than 10 centimeters. Is it because the tumor's been around longer? Do we think those are just more inherently more aggressive? I'm not sure that we know.
We do not. I agree with you on that. My own suspicion is that basically it speaks to the biology of the tumor. I think given that those tumors tend to do more poorly, they probably grow up a little faster than the others. Although I do not know any studies that looked at the Ki-67 in the indices or on other things that showed that there's actually a difference relating to the size of the tumor.
Yeah, and one last question before others make comments is, you and I have there's always been this question about the different location of the tumors and whether there's differences, right, in terms of the behavior and stuff. And that's something you and I have talked about for probably 20 years, right?
Absolutely. And I had some data that I wish I could put in the talk as well. We looked at, not me, but some of the people have looked at epigenetic expressions of these tumors in various locations, whether it be in the skull base or in the spine and sacrum. There appears to be differences, and they may be driving these different biological behaviors. As you know, skull-based chordomas, they tend to be a little bit more indolent. They are much more responsive to radiation, whereas the spinal and the sacral chordomas tend to be much more resistant.
No, that's very interesting. So the methylation in the epigenetics may be something that's very very important. Other questions or comments, please.
Yeah, I have a question. Thank you for a great talk. Just any thoughts about BNCTs and how do you monitor BNCTs in your current practice? Do you monitor them with MRIs? Any thoughts about theories of transformation into chordomas? What do you tell your patients?
Yeah, that's an excellent question. As far as notochordal rest, I think that I believe the question is related to notochordal rest. Is that correct? Yes.
Right, benign notochordal tumors. Yes.
Yeah, and so those are tough, I would say. At least the way that I monitor them is I usually look at the CAT scan very critically. And if the CAT scan, on the CAT scan, if there's no lytic abnormality and the bony architecture appears to be normal or close to normal, or maybe sometimes a little bit sclerotic, but there is no evidence of destruction. And that, to me, clinically suggests more of a benign behavior. And then I do follow the CAT scan to see whether or not this is going to turn into a lytic lesion, which in my view is an indication for transformation to chordoma, or it's breaking through the anterior cortex of the vertebra and so forth. And of course, monitor the size of it if the size is gradually increasing over time. But I found, at least in my own experience, The tumors that respect the bony architecture on the CAT scan, they tend to remain stable. And those that cause destruction, either they are chordomas or they are transforming to chordomas. Did I answer your question?
Alan, do you have any,
No, Zia, terrific job again. Incredible technical demonstration of what needs to be done for these cases. And you know, I was just wondering, you know, as you moved from these places, MD Anderson and Hopkins and now in Rhode Island, you know, you're often the person of last resort in terms of the referrals. And I'm sure you see tons of patients who have had, you know, little tiny laminectomies and biopsies and closed, and then they send them to you and say, hey, here's a chordoma. You know, once that happens, what is your attitude about curative resection? I mean, you showed an example of that with that epithelioid sarcoma, but I'm sure you see a ton of secondary referrals of chordomas. What's your attitude in those cases?
Yeah, I mean, I think that in many situations, it's an issue that we discuss extensively with the patient and make a decision jointly. If the tumor has already been violated and there is tissue contamination, our chances of curing that tumor are very, very small. I would say the exception to the rule would be maybe sacral chordoma case where they thought that it was a pilonidal cyst or something. They entered the tumor, and I can go ahead and resect everything along the incision, along the surgical field, and along with the surgical field, previous surgical site. If I can achieve that, I think there is a chance of cure. But if the tumor has already been violated, the chance of achieving that is very small. Having said that, I still do believe that the best resection that you can do, even in those cases, coupled with proton beam or other types of focal radiation strategies, respecting the patient's function as best as you can, are the best way to deal with those cases. I think that when you take a very nihilistic approach from onset, because the patient had a surgical procedure and a biopsy or limited resection, and the field is contaminated, those patients tend to do very poorly. They keep coming back with recurrences, and eventually they fail very quickly. And for that reason, I tend to be quite aggressive, try to clean it out as best as I can, and then send the patient to adjuvant radiation after that.
yeah, well, maybe that's a great question, Alan. Some of these patients come in and have had multiple procedures, you know, 8, 9 procedures, and they really, we need to get them on some of those clinical trials based on some of that research data you presented, Zia.
Yeah.
And the last question I had is, you know, there's this, you know, at in New York with Mark Bilski, who I have enormous amount of respect for. You know, he's sort of changing the thinking in some ways of some of these sacral chordomas and deciding to, you know, upfront very high dose radiation, sometimes even no surgery. And I just wondered what your thoughts about that was.
I'm really intrigued with that. I have to tell you, that's why I looked at the radiation data more critically to see if there was support for that. One difference is that the way that they treat the chordomas is a single fraction, 24 grays of radiation, which has a biological equivalence of about 120 grays of radiation to the site. So it is a very, very high dose of radiation to the target. And that's how they treat their single metastases and whatnot. And that's why they are able to achieve pretty good results. I don't think many radiation oncologists would not really feel comfortable giving that dose of radiation, even compared to carbon ion, for example, which is, I think, 100 grades of radiation to the target, whereas, you know, with stereotactic surgery, you're even exceeding that. So that may be the reason why the results are more durable. And still, I mean, I'm waiting to see clinical data, more clinical data, to see whether or not that's going to pan out. My original thought was that if you look at what we were able to achieve with proton beam radiation, when the proton beam radiation first came out, people said that here's a cure for you. We're going to use the radiation to cure chordomas. And we could not, right? So we are dealing with the patients who have repeatedly failed proton beam radiation. So in my view, why is that going to be different with stereotactic radiosurgery? Maybe the answer in the fact that it's much higher dose of radiation, like it is with the carbon ion, but I don't know the answer to that.
But some of those patients that have such high dose in that one fraction have had horrible wound complications. And as you know, Zia, from when I was at Mass General, some of the patients that I had, we didn't have local recurrence, but the complications secondary to the treatment were significant, including an increasing number of radiation-induced sarcomas from our protons.
Yeah, so I've seen some of those patients and I've seen some of those complications. They are horrific. And the other thing that to keep in mind is that you are really burning all your surgical bridges. When you subject the patient to carbon ion radiation or stereotactic radiosurgery, for that matter, for that dose of radiation, going back and doing any type of surgical procedure is horrific with respect to surgical complications. And Fran has a lot of experience dealing with it at MGH. Many of these patients are left with disabling neuropathies, non-healing incisions, constant drainage and wound complications and secondary tumors for that matter. So I think that needs to be discussed with the patient upfront and saying that if you're not going to have surgery, remember, your surgical option is probably off the table if you go straight to other treatments.
I think Frank and Mike had comments.
Yeah, Zia, would you make any comments about doing anterior procedures on patients who've already had high doses of radiation regarding the blood vessels, especially inferior vena cava, iliac veins?
Yeah, it is very treacherous. Let me put it that way. We get our vascular surgeons involved in all of the cases, first of all. And then number two, we get our interventional people involved because some of these cases actually require upfront mesh placement and other things so that you can avoid some of the intraoperative disasters. And then the other thing that we have seen, which is horrific, is that sometimes after the resection of the tumor, you get a small leak, but you don't necessarily recognize it from either the venous structures or sometimes from the arteries. There were a little leak. And then, a couple of weeks later, you go back in there and there's this massive lake of blood that the entire spine is sitting in. And when you get an angiogram, you don't even see the vasculature, sort of disintegrated and fused to the space that you operated on. Absolute nightmare. But all I can say is that it's always to have the experts to deal with them. And in some cases, we abandoned the operation. We just couldn't execute it because of the vascular issues. Sometimes we cut it out and replace it with grafts, if at all possible. But then you have to really ask the question whether or not it is worth doing that operation in that patient. Are you really achieving the oncological objective there?
Another question, Zia. So it seems like someone comes into the emergency room, a middle-aged person, and they're having some new neurologic deficit, whatever, like the kind of early stage neurologic deficit, and they're taking the surgery immediately to decompress the neural elements. And then the biopsies come back later that it was, for example, chordoma or something else that could have been resected. What's the role and what's the limit for people to proceed with decompression without having biopsies? I mean, when is that indicated for?
Yeah, so
obviously
it's an excellent question, and unfortunately, I see this over and over again. Having said that, I would never be critical of a surgeon who sees a patient at 2 o'clock in the morning, who is dealing with a patient who is neurologically compromised or declining, and they make the best decision and best judgment at that moment. So it is always easier to be the Monday morning, what they call a quarter, making that decision in hindsight and say, well, you should have done this, that, or the other. Well, if you were going to do that, I wish you had seen the patient at 2 o'clock in the morning when they were about to become paralyzed, and you're not in my shoes, and you cannot make that decision. I 100% agree with that. So I don't think that, we should really, I never tell the patient that was the wrong thing to do. They did the best they could under the circumstances. I would have done the same thing. And here you are now. Let's deal with what we found and how we're going to treat the patient. Having said that, I think we do have a low threshold justifying surgical procedure when the patient has even minor neurological deficit. If somebody has a little bit of a leg weakness, they've been going on for a number of days, and the patient shows up in the emergency room, and your reflex is always the patient's neurological compromise. I don't know what it is, but I'll do an operation, we'll find out what it is. Whereas it's much easier and better, I would say, if you were to take the time to do a biopsy. In many cases, you have the time. In some, you don't. But in many cases, you have the time, protect the patient with some steroids and do a biopsy and see if you can get the answer before you subject the patient to a surgical procedure. But having said that, I would never be critical of anybody who did the operation at 2:00 in the morning, and that's what they thought was the best thing to do for that patient.
Mike?
Zia, that's fantastic. What a tour de force. I know all the residents in ortho neuro are just salivating about how do we do surgery the way you do. My question has to do with the surgical reconstruction. So you show just fantastic work with creativity and how you're reconstructing the spine. And we know that there's a burgeoning market of using alternative materials besides titanium stainless steel. What do you think this is headed? Do you think that is really the way to go, or are you still using titanium stainless steel for all your reconstructions? Because that's what works best for this. That's what gives you the latitude for individualizing the reconstruction.
Excellent question. Particularly carbon implants are coming in, and they are out there already. And there are numerous advantages associated with using those implants, particularly if you're planning postoperative proton beam radiation, other forms of radiation. Having said that, those implants are still very difficult to use, and it takes a lot of time in the OR to be able to. You cannot bend the rods, and they have to be pre-bent, and they have to have the possible options, etc. And that's why I resort to titanium for the most part. Occasionally, I would put the screws above the area of the tumor, above and below, or maybe use a PEEK or a carbon fiber cage to be able to minimize the artifact in the area where the tumor was or was going to be targeted. Where the other sites, I use regular titanium screws or others. And so, and sometimes the rod alone doesn't really produce a lot of artifact. So you can still use titanium rods or other types of rods, not necessarily carbon fiber, because the artifact from the rod tends to be very limited. Majority of the artifact comes from the screws and the cages.
Thank you very much.
You're very welcome.
No, this has been great. I think it's 8, a little bit afterwards, and I know the residents are anxious to show you some cases. So perhaps we can start with that. I'm not sure who from either. I know there have been some people assigned from both sides, Zia